Hello, everyone. I'm going to talk about the Minnesota Multiphasic Personality Inventory for this short presentation. Um, First, I'm going to go over the theoretical basis for the Minnesota Multiphasic Personality Inventory, which I'm going to, from now on, call MMPI. So the original MMPI was developed in the late 1930s, and it was used as an instrument to diagnose mental health problems within medical settings. And it was based on scaled descriptions of personality inventories. The test was constructed based on empirical research that differentially associated the results of each of 10 clinical scales with patients known to have psychopathologies versus the norm group without these psychopathologies. Although the basis for the original MMPI is often applauded as being atheoretical, as the initial test was not aligned with prevailing psychodynamic theories of the 30s, many take issue with this because, after all, the MMPI was constructed based on existing psychiatric knowledge of the time and diagnoses, therefore. So I'm going to talk about the basic format and administration of the test. So the MMPI is available only to level C certified examiners and is designed for use with those who are above 18 years of age. It takes about 60 to 90 minutes to complete. So basically what I'm saying is the test can only be used by qualified psychologists with additional training in test scoring instruments. The original MMPI was administered using a test booklet on paper, and it had 550 true or false questions, and separate versions were actually given to male and female test takers. The original version used a paper answer sheet with hand scoring and plotting on this XY graph. Currently, electronically administered and computer scored options are available, thankfully. The publisher advises that the test be adequately supervised. And how they define that is that a trained proctor should be available and should be able to see the test taker at all times. Recently, with telemedicine, this is available. However, the recommendations are the proctor should at all times still have visual and auditory sort of access to the test taker. So I'm going to talk a little bit about evidence for validity and reliability of this original MMPI. So the norm group was rural Minnesotans with an average of 8 years of education who worked as semi-skilled laborers and farmers. So a clinical raw score was calculated based on the number of true versus false answers for each of these 10 scales. And I'll show you these scales. So they are hypochondriasis, so concern with bodily symptoms, depression, depressive symptoms, hysteria, sort of a hyper-awareness of problems and vulnerabilities, psychopathic deviant, so someone who had conflict and struggle and anger, and sort of not a lot of respect for rules. Masculinity, femininity, so stereotypical interests and behaviors. Paranoia, so looking at a level of trust, suspiciousness, sensitivity to what's going around them. Psychoesthesia, which means like worry, anxiety, doubt, sort of obsessive compulsiveness. Schizophrenia, kind of odd thinking and social alienation. Hypomania, kind of a level of excitability. And social introversion, so people that weren't necessarily well-oriented to other people. So raw scores were calculated between the normative and groups, and T-scores were calculated 50, as we remember was the average with a standard deviation of 10. So some original papers, boy, what a morass, but there really weren't a lot of good data on validity and reliability for the original paper, but I'm going to get to that with the revised version, the MMPI-2. So the type of scales. So again, we talked about, so there are actually validity scales. So the first four of these, CNS, L, F, and K, were part of this MMPI-1. So validity, it's trying to say, is the test truly measuring what we think it is? So they're kind of looking at the test taker. So CNS would be a lot of questions were not simply answers. So obviously that's going to affect the validity. Lie would be the client is kind of faking good answers, trying to seem more healthy or better than they are. And then F would be they're faking bad. So are they trying to seem worse than they are for maybe some type of gain? And then defensiveness, they're just not really answering the questions reliably and openly and honestly. And so as I said, there's other versions available today. So we have this MMPIA, which is a version that's given to adolescents, a shortened reformatted version, the MMRF2, and the most widely used version in 40 different languages today is the MMPI2, with just probably 1,000 of research studies I saw when researching for this talk. So in developing this version, many test items were revised based on using a more diverse norm population, because remember we talked about the first population was white rural Minnesotans, and then the reading level was simplified. Some extra questions were added, so the number of items was actually increased from 550 to 567. They did away with separate tests for those identifying as male and female. However, they do have gender-based norming scales. So additional validity tests were added. You can see those here. You can read them. FB, faking bad. So that's in the last half of the test. And then variable response inconsistency, answering similar opposite pairs inconsistently, TRIN, true response inconsistency, answering questions they're all true or all false. F-K, honesty of test responses, so not faking good or bad. Superlative self-presentation, so appearing excessively good, and then frequency of presenting clinical symptoms, and then over-reporting. So do they report a lot of pathological symptoms at one time and increase over time? So each scale's validity score is broadly categorized, like non-responding, random responding, fixed responding, over and under reporting. So they're translated into T-scores, which you can see on the y-axis. And then the T-scores have cutoff scores, which is typically 70. So roughly 2 standard deviations above the mean is usually the cutoff score. And that's pretty consistent along these 10 kind of clinical scales that you see here. The retest reliability. So it gets kind of tricky because you're looking at each of the 10 scales. So I'm going to give you a range, which was 0.5 to 8. The first scale, hypochondriasis, is the most reliable, 0.8. The Cronbach alpha scores range between 0.58 and 0.59. And the outliers were paranoia and overt hostility. So if we remember from our class, a coefficient of 0.7 for clinical applications is kind of used as an acceptable cutoff. But one of the interesting things, like Cronbach alpha is measuring a measure of internal consistency, and so we don't necessarily expect sometimes these to be internally consistent because they weren't selected to be consistent with each other. They were selected to differentiate between this diagnostic group and the normative group. So last couple slides. Clinical applications. So originally it was identification of psychopathology in clinical and mental health settings, but this test has actually been used to determine child custody, employment suitability, particularly in the military, police, personal injury cases, pretrial criminal investigation, and then competency decisions. Now, some sort of argue that it's really going against the original application, and we have to be careful when we branch out into these different applications that we don't have really a full set of data for. There are some ethical and cultural considerations, and there's considerable racial bias that actually exist here on this test. So when scores were compared among white, black, and Hispanic men, non-whites scored about 5 points higher on T-scores with questions that measured validity on lying and exaggerating and indicated psychopathology like schizophrenia and mania. And so as the test was normed against white, middle class, rural people, The test results are thought to kind of they reflect cultural bias rather than actual difference between these populations. And then that was for the MMPI-1. For the MMP2, which we use today and actually has a more diverse cultural group, similar results were found with elevated T-scores when you looked at schizophrenia and mania when African American male results were compared to Caucasians. So we just have to be very cautious when we interpret these results still today against non-white populations. Thank you for your time. I hope you enjoyed the video.